Welcome, everybody. This is the first JVS-Vascular Science webinar of 2022. We've had several webinars in the last couple of years, and they've been very successful. I suggest that everybody look at our homepage, www.jvs-vs.org, and you'll be able to see the previous editions of the webinar. And when we're done, this webinar will also appear on the homepage so that you can go back to it. And if you missed anything, it'll be available for you. So my name is Dardik. I'm the editor of JVS-Vascular Science. I'd just like to thank everybody for your contributions to the journal. I thank the speakers that are here. I especially thank our three presenters who were chosen because of their papers that they published in the journal. One of the really wonderful features of our journal is our editors choose from the accepted papers some that really stand out. So these papers stand out, and we ask our authors to present them to us. That's a real benefit, what we hope that you get from publishing in our journal. So thank you all for participating, presenting your work. And I'm going to turn this over now to Dr. Paul DiMuzio, our assistant editor for social media and presence, who will tell us about the webinar. Dr. DiMuzio.
Thanks, Alan. Good afternoon, everyone. Just as a reminder, the webinar is going to be recorded and will be sent out in the next few days for viewing and also memorialized on the web, as Alan said. Please post any of your comments or questions on the chat so the discussants can pick them up and add them to the conversation. And kindly keep your computer on mute throughout the program. And with that, I will introduce Dr. Gale Tang, Associate Editor of the JVS-Vascular Science, who will get us going. Thanks again.
So I have the pleasure of introducing Dr. Ryan McEnaney, who is our invited speaker for this webinar. He's going to speak about extracellular matrix remodeling in arteriogenesis. Take it away.
Thank you, Gale. Thank you, Dr. DiMuzio. Thank you to all the editors of the JVS Vascular Science for putting on these webinars. I think they're just outstanding, and I'm very grateful to be able to be talking to you today about arteriogenesis. I'll be speaking with you about arteriogenesis, and namely the extracellular matrix remodeling that occurs, really that permits the development of functioning collateral arteries. There is a lot I want to show you, and not a ton of time, so I'm going to jump right in. I do not have any disclosures. So for those of you who may not be really familiar with what arteriogenesis is, it really is the process of collateral artery development. This is a natural adaptation to arterial occlusive disease. In other words, when a conductance artery becomes obstructed, naturally within the arterial network, flow patterns shift quite dramatically in some cases, and can exert certain pressures on smaller, in particular, interconnecting blood vessels. The resident cells, namely the endothelium, the vascular smooth muscle cells that exist in those candidate collateral arteries, pick up on those flow pattern shifts and initiate these process of remodeling in order to become functioning and useful collateral arteries. Arteriogenesis, though, really begins in development. It's not possible to develop real collateral arteries without the existence of these pre-existing interterritorial connections. There is some number of arterioles which don't terminate into capillary beds within a target organ, but rather connect directly to other arterioles that may be fed from a different parent artery. This apparently is a heritable trait and has been studied pretty extensively in mice, and has been thought to account for a lot of the differences in various mouse strains response to femoral artery ligation. Some mice strain, like the C57 Black 6 mouse strain, is notoriously efficient at perfusion recovery after femoral artery ligation, and is thought to be perform arteriogenesis rather efficiently. But the BALB-C strain, on the other hand, is notoriously poor at perfusion recovery after femoral artery ligation. These animals tend to suffer severe consequences of ischemia, tissue loss, and one of the major factors accounting for this difference is the presence or absence of these pre-existing interarteriolar connections. I would suggest that in the case of human collateral arteries, being a vascular surgeon, we see a lot of arteriograms. On the left, you see a normal arteriogram, and on the right, a similar arteriogram of a similar anatomical location, but with the occlusion of the conductance vessel. The large collateral arteries shown here are not created de novo, but rather are expansions of these sort of pre-existing connections between territories, namely the descending genicular vessel and muscular branch of the posterior tibial artery. So when an occlusion occurs within a conductance artery, flow patterns shift, as I mentioned, and schematically shown here, a candidate collateral artery, which is a interconnection between two different territories fed by two different parent vessels, will experience a dramatic change in the flow patterns. The initial response to that flow pattern change is activation of the endothelium and vasodilation, but that can only get you so far. To achieve the sort of diameter expansions that we see in collateral arteries, especially functioning collateral arteries clinically, there has to be more of a structural remodeling that occurs. And one of the most interesting things about arterial structures to me is the vast majority of the mechanical properties of an artery boil down to the interrelated interactions between the extracellular matrix components, the two most prominent being elastin and collagen. So to really look at arteriogenesis and the remodeling of the extracellular matrix, we first started by defining what the baseline structure of these blood vessels tends to be. And for anyone interested, we published this survey, this detailed look at the internal elastic lamina and the extracellular matrix in general of various arteries within the arterial tree in the JVS-Vascular Science. What I would highlight here is that most arteries, as expected, share a pretty similar structure of the internal elastic lamina being a thick sheet of elastin punctuated by small fenestrations. But certain blood vessels, derivative branches like the profunda or these muscular arterioles have a different morphology in the internal elastic lamina. And that is important, I think, because these tend to be the blood vessels where outward remodeling in arteriogenesis occurs most prominently. Just to expand a more zoomed in look at the structure here, the internal elastic lamina doesn't so much appear as a thick sheet of elastin as it does maybe cords of elastic tissue that are intermittently fused together. The fenestrations or the empty space look more like elliptical fenestrations. Again, I won't dwell too much on this given the time. So with this baseline structure in mind, we used a model that we sort of modified in a rat to really augment pressure for outward remodeling of these collateral networks. Namely, we did a standard femoral artery ligation, but we constructed an arteriovenous fistula distal to it, such that the flow across these territories was really dramatically augmented. And this is very effective at creating larger outward remodeling in the profunda vessel in particular. In the rat, we can see 2.5 to 3 times the diameter expansion over the sham operated vessels. When we looked at similar the extracellular matrix structure, and what you're seeing here, I apologize not spelling that earlier, but these are multi-photon microscopic images on FUS. So we're looking at the surface of the luminal surface of the blood vessel. And what we see is that with this outward remodeling, there's really a dispersion of these bundles of elastic tissue that occurs within the profunda. There isn't so much a change in the morphology of the collagen, however. What's notable, or what I found notable certainly, is that despite the relatively dramatic increases in size and mass of the derivative collateral artery, we didn't really see the amount of elastic tissue ever scale up to accommodate that. Notably, when we looked at evidence of elastic degradation within this model of arteriogenesis, we certainly saw evidence that elastin was being proteolytically degraded with spikes in serum desmosine evident in the first 7 days that sort of falls back to baseline. But sort of back to the my previous point, when we looked at the tissue content of elastin using total desmosine as a surrogate, we did not see any increase in desmosine as I might expect, despite the fact that the vessel itself is increasing in size quite dramatically. What is probably more striking is that the smaller the blood vessel, the relatively sparser the amount of elastin at baseline. The small interarteriolar connections have very thin bands of elastic tissue to begin with. These blood vessels, on the other hand, when they expand in arteriogenesis in our model, increase diameter sometimes several orders of magnitude, going from 10 micron diameters to sometimes 100 to 200 microns in diameter. When we looked at the resultant internal elastic lamina and adventitial collagens, what we see is in large expansions such as these, we see that the internal elastic lamina appears to be stretched very thin and possibly overburdened with strand breaks evident. Number 4 here, these numbers correspond to this casting of the arterial tree. And number 4 over here corresponds to this these images here, where we see that the internal elastic lamina appears to have been lost entirely. What's notable then is the morphology of the collagen and the adventitia becomes straightened. And this is suggestive of mechanical loading of the adventitial collagens in this situation. This morphology of these very small collaterals that had undergone such dramatic expansion is very similar to blood vessels treated with intraluminal elastase, where the internal elastic lamina was enzymatically degraded. We see a very similar pattern of IEL loss and loading of the adventitial collagens. And that is just described here in very basic terms with an undulation index. Again, if any interested listeners should check out the references where this is published. So in looking at this, we took developing collateral arteries and performed mRNA isolations and RT-PCR. And basically the takeaway from that is that During arteriogenesis, there is a simultaneous increase in expression in both proteolytic factors as well as elastolytic factors and expansion of the extracellular matrix. And a couple of the things that I just briefly want to highlight are the increases in tropoelastin and lysyl oxidase. We subsequently mirrored these findings in human coronary arterial endothelial cells, rather, undergoing increased shear stress in a flow chamber, and found that in that situation, the endothelium is also responsible for producing this increased lysyl oxidase and tropoelastin expression in response to increased fluid shear stress. When we looked at this in terms of arteriogenesis, what I want you to take away is that lysyl oxidase is apparently necessary for the stabilization of the internal elastic lamina during arteriogenesis. So while we don't see increased elastic tissue being deposited, we do see tropoelastin being expressed. And what we found was that if we inhibited lysyl oxidase during arteriogenesis, after the FAL plus AVF model was initiated, that didn't alter the outward expansion, but what we did see was that the internal elastic lamina appeared frayed with numerous strand breaks, and over time we observed that the internal elastic lamina appeared to be lost entirely. Once again, when this occurs, we see that the adventitial collagen morphology becomes altered with straightening of the collagen bundles, and this again implies mechanical loading of the adventitial collagens. So in looking at all this, one question that comes to my mind is, does this outward remodeling in arteriogenesis, does this create a mechanical vulnerability to failure or other degeneration? So I want to call your attention to this image in the lower right, this transitional image from the parent artery, which in the rat is called the superficial epigastric artery, to the profunda. There's a rather abrupt structural change that occurs normally. And then in the case of this remodeling that occurs in arteriogenesis, you see that there's a lot of fraying and a lot of damage that appears in the product IEL. So the reason I bring this up is because there are some clinical entities that are curiously associated with hemodynamic changes and in particular collateral arteries. And so I just wanted to throw out this idea. For instance, pancreatico-duodenal artery aneurysms have actually long been associated with collateral networks in the visceral arcades, namely celiac arterial obstructions are basically considered to be a pathophysiologic factor in the development of PDA aneurysms. And this has been shown in one recent series that basically the majority of either PDA or GDA aneurysms actually results in association with celiac artery occlusion. In another instance, intracranial aneurysms have been long associated with hemodynamic factors. They tend to occur at bifurcations, and there's a lot of literature regarding the hemodynamic factors that cause this aneurysm type remodeling that leads to disruption of the IEL, expansion of fenestrations, and perhaps weakening of the arterial tissue, and that this may be a sort of predisposing factor into the development of these aneurysms. So just to summarize, outward remodeling is necessary for arteriogenesis and collateral development. This arteriogenesis depends heavily on the baseline extracellular matrix structure. Again, interestingly to me, at least, there does not appear to be any increase in polymerized elastin that occurs in the extracellular matrix, despite the sometimes dramatic growth of the vessel itself through remodeling. The maintenance of continuity of the internal elastic lamina then depends on simultaneously repairing and rebuilding the elastic tissue during this expansion, which requires some element of proteolysis. What we have seen, at least in the model thus far, is if the continuity of the internal elastic lamina is lost, then it does not get replaced. The adventitial collagens then become load-bearing and must bear the brunt of the hydrostatic pressure. Finally, they suggest that the remodeled extracellular matrix may be mechanically weakened or possibly vulnerable to mechanical failure. I want to acknowledge everyone that works in our lab: Dylan, Nolan, Elizabeth, and Rohan, shown here, all my collaborators, and the funding sources for our lab at the VA and the Vascular Cures Foundation. Thank you very much once again for this opportunity to talk to you about arteriogenesis, and hopefully I didn't go too over in time.
So unfortunately, there are a couple questions that are in the chat, but we don't have enough time to openly discuss them without robbing this other speakers. So I'll ask Dr. McEnaney to just answer them in the chat directly. So we need to move on to our next speaker, Dr. Mohammad Qadura, who will be talking about fatty acid binding protein 3 is associated with peripheral arterial disease, presenting from St. Michael's Hospital in Toronto, Ontario. Dr. Qadura.
Thank you so much. So thank you once again for this great opportunity and the privilege to speak to everybody. In summary, today I'll be chatting to you about how my research team is very keen on proposing that fatty acid binding protein 3 could be utilized as a potential biomarker for PAD. To do so, we constructed this pilot study in a case control fashion on 75 patients with PAD as well as 75 patients without PAD. We measured the plasma levels of FABP3 in these patient populations, and in addition to localizing FABP3 expression within skeletal muscles isolated from patients with peripheral limb ischemia or basically healthy individuals. In order to dig into details, we'll go over a few slides. And once again, this is me, and I'm presenting on behalf of my very productive research team here in Toronto, Canada. First, I would like to announce that I have no disclosures. I believe that everybody in the audience knows how bad peripheral arterial disease is. Unfortunately, it's just like the middle child. It's not well, doesn't deserve the attention it seeks. But believe it or not, peripheral arterial disease is a major problem, not here in North America only, but globally. Almost 150 million individuals suffer from PAD globally, which is roughly the sum of both patients suffering from coronary artery disease or carotid vascular disease as well. In North America, we have almost 15 patients with PAD. At least in Canada, but I do presume similar numbers in the US. Unfortunately, many patients go undiagnosed, or basically they get diagnosed late in their disease status. And there's a significant pathophysiology behind this, which we will not go into details. But as healthcare providers, unfortunately, we see the front end of these complications. In Canada, the average cost for the annual hospitalization of patients with PAD is roughly about $5,000. And an amputation on annual basis costs our healthcare system about $70,000. So it's a major problem on patients, in addition to us as healthcare providers on the healthcare system, and it's a big problem since it's global and it's poorly diagnosed. Our group, in addition to others, run basically a couple of surveys to learn on why this is a major issue, and it stems from the diagnostic tools that we have. Most of the diagnostic tools that is available for physicians, mainly either radiographical based or in addition to clinical exam. The ankle brachial index is the most simple form on how we can diagnose patients with PED. And unfortunately, we do not have a blood-based biomarker yet. We run a couple of surveys just to learn on why this is an issue. We learned that in order to conduct the most simplest form to diagnose patients with PED, which is the ABI, it requires extensive staff training. It's usually unreliable in some patient populations with diabetes, especially if they have non-compressible ABIs. It's time consuming, and there's limited centers which can actually afford this diagnostic test. So we wanted to propose a specific marker for PED, and we thought, let's think backwards. So we did some proteomics and tried to basically identify the proteins that are mainly expressed within skeletal muscles. And we stumbled across fatty acid binding protein 3 while we were doing our mass spectrometry analysis. We learned that FABP3 belongs to a multi-family of fatty acid binding proteins. It is almost over 95% expressed in skeletal muscles as well as cardiac muscles, very minimally in other tissues. And it's mainly an intracellular protein that's not usually present extracellularly, but it gets released after basically an insult to the muscle, whether it's ischemia, injury, etc. So we thought it might be a good candidate to work with. So our hypothesis was, can we use FABP3 as a marker for PED, and is it elevated in this patient population? So this will be the first step, and this will be hopefully my dream before I retire, in introducing the ACS equivalent, the troponin in this patient population. So we need a blood-based marker to diagnose our patient population. So could FABP3 be this troponin ACS equivalent? To do so, we ran this trial at San Michael Hospital here in downtown Toronto. It was in a case-controlled fashion. Within a year, we recruited 75 patients with PED, in addition to 75 patients without PED. We also recruited 3 patients with chronic limb-threatening ischemia, where we isolated the skeletal muscles from those individuals, in addition to 3 other individuals without peripheral arterial disease, which we were able to get muscle biopsies from the skeletal muscles. With such a design, we were able to measure the levels of FABP3 within blood vessels, in addition to localize the level and expression of fatty acid binding protein 3 within skeletal muscle. So as you can see on this slide, basically we have the patients with and without PED, and it goes without saying that patients with peripheral arterial disease usually have significant cardiovascular morbidities, just like hypertension, hypercholesterolemia, diabetes, and almost every single variable that we measured was significantly elevated or worsened in patients with PED relative to their counterparts. So the most simple experiment we did is basically measure the levels of FABP3 in this patient population. I also would like to say that we also co-measured the level of troponin I in these individuals, just to ensure that troponin I is not elevated, because as I mentioned earlier, fatty acid binding protein 3 is also released by the myocardium. We just want to make sure that the observed level of FABP3 is elevated due to other sources within the skeletal muscles, but not the myocardium. We noted that in patients with PED, the levels are significantly elevated. It's almost 3.9 nanograms per milliliters relative to patients without PED, which is about almost 2.27. Since we had a small sample size, about 75 patients per group, we could not really do very in-depth statistical analysis. However, we've done some subgroup analysis. As you can see on this slide, on the x-axis, you have basically the disease of the confounding factors we'll have to study, which is coronary artery disease on this side, and diabetes from this other side. On your y-axis are the level of the fatty acid binding protein 3. As you can notice in the bar charts, that the shaded groups are the num-pads, and the solid line is the pads, regardless of the background, whether they're diabetics or whether without coronary artery disease. The the level of fatty acid binding protein 3 was constantly elevated in individuals with a background of PED, regardless if they were positive or negative for coronary artery disease or diabetes. Next, we basically segregated our patients based on their severity, and we used basically the ankle brachial index as a gauge to help us identify the severity groups. So you have patients here on the x-axis of healthy, between ABI of 0.4 to 0.9, less than 0.4, and non-compressible ABI on your y-axis, the FABP3. And you can see basically the levels of the protein is elevated as the disease status worsen. Also, Spearman correlation analysis showed an indirect relationship between the levels of FABP3 and ABI, which makes sense that as the ABI is reduced, when it goes down, the levels of FABP3 goes up, demonstrating a negative relationship between ABI and fatty acid binding protein 3. Last, basically, we wanted to localize the level of the expression level of fatty acid binding protein 3, and to demonstrate that's also expressed within skeletal muscles. So I went to my colleagues in cardiac surgery, and we managed to get some appendages from the atrium after doing a cabbage. And of course, recruited 3 patients without PED, and we got those skeletal muscles from biopsies while we're doing managements for the varicose veins, in addition to patients with curricular limb ischemia who unfortunately required an amputation. We were able to get some muscle biopsies. On panels A, C, and E, it's basically your typical H&E staining. On panels B, D, and F, basically we stained for fatty acid binding protein 3. And as you can see, the levels of FABP3 were elevated in the myocardiocytes and in patients with chronic limb-threatening ischemia, as demonstrated with this little brown discoloration, and is barely not elevated in patients with non-PAD. So to summarize, we've demonstrated in this policy that fatty acid binding protein 3 is elevated in patients with PAD. There's an association between the disease severity and PAD, and it's reflecting a negative correlation between FABP3 and the ankle brachial index, and it built basically the foundation for a larger trial that we're currently running in order to utilize this biomarker as a diagnostic marker for PAD. With this, I would like to thank everybody for their attention. I'm happy to answer any questions if time permits. Thank you.
Just a quick reminder for people to please put their questions in the chat, which I will be moderating. So Dr. Qadura, you had, the average ages were very young in the non-PAD group. Did you have, was there any sense that there was any difference in terms of as patients got older, whether their FAB3 levels went up?
Absolutely. As we also know that PAD is also a disease of age. Usually we tend to see it in patients who are a bit more older. In the largest trial that we concluded almost a year and a bit ago, where we have over 800 patients recruited, we were able to adjust and account for age. And we noticed actually there's a link between FABP3 and age. But despite of accounting for that in our subgroup analysis, we identified that it was basically not a major contributor to the levels that we observed.
In interest of time, we're going to move ahead to the second speaker. So this is Dr. Antoine Ribieras, who will be speaking on gangrene, revascularization, and limb function improved with E-selectin adeno-associated virus gene therapy from the University of Miami. Dr. Ribieras.
Hi, everybody. My name is Antoine. Thank you so much for the opportunity to speak with you today. So just very briefly, I'll be discussing a novel gene therapy that we developed in our lab based on the E-selectin, which is a cell adhesion molecule important for neovascularization. And we tested this gene therapy construct in a mouse model of hind limb gangrene. So just some very brief background. Up to about 12% of patients with peripheral arterial disease suffer from chronic limb-threatening ischemia, which is the most severe form of PAD and is associated with significant morbidity and mortality. While surgical revascularization is the mainstay of treatment for these patients, unfortunately, up to 30% of them are either not candidates for or they have failed prior revascularization attempts. And so for these patients, we've been working on novel methods for improving perfusion to ischemic limbs. Like I briefly mentioned, E-selectin is a cell adhesion molecule, and it is its expression is induced by ischemia and tissue injury on endothelial cells. And via expression of E-selectin, the endothelium is able to recruit leukocytes and, importantly, endothelial progenitor cells to areas of ischemia and wound healing. And in this way, these endothelial progenitor cells are able to participate in neovascularization. So our overarching goal has been to increase the tissue levels of E-selectin to basically improve recruitment of endothelial progenitor cells and hopefully improve perfusion to the ischemic limb. And this is briefly our experimental protocol. We used FBB mice, which are sort of have an intermediate susceptibility to ischemia. We treat the mice with either E-selectin AAV29 or LAC-Z AAV29 as control. The vector we're using is an adeno-associated virus vector, which has a good track record of safety in other therapeutic applications. And the gene therapy is administered 4 and 2 days before surgery and on the day of surgery. To induce ischemia, we perform femoral artery ligation at the 2 sites shown in the image on the right. And in addition, we administer L-NAME, which is a nitric oxide synthase inhibitor. This further increases oxidative stress in the limb and induces gangrenous changes in the footpad of these mice. So the first outcome we look at is just the gross appearance of the foot, in which we can score based on the Faber-Heinlein ischemia score, with some examples there shown on the left. And basically you can see by post-op day 7 and certainly by post-op day 14, the mean Faber scores are lower in the E-selectin treated mice, basically demonstrating that they have reduced severity of tissue loss. Like many other studies of Heinlein ischemia, we assess reperfusion to the footpad post-op day 7, post-op day 14. And similarly, we can see that perfusion is improved in the E-selectin treated mice with a significant difference 2 weeks after surgery. This slide demonstrates another technique whereby we can look at the microvasculature in the footpad. This is dye perfusion with the fluorescent dye eye. We perform this again 2 weeks after surgery. It's via intracardiac perfusion, and then we harvest the feet. On the left, the 2 left images are unligated or non-ischemic feet, so normal feet. And then the 2 images in the middle demonstrate a LAC-Z mouse on the left compared to an E-selectin treated mouse on the right. And you can see in that image improved reperfusion of the footpad, which is quantified in the graph on the right. So then we harvest the muscle again at the same time point 2 weeks after surgery and do some histological analysis. So this here is just demonstrating E-selectin expression in the local vasculature. So in the top larger image, this is a co-staining for CD31, an endothelial cell marker, as well as E-selectin. You can see E-selectin expression specifically in those endothelial cells. Whereas in the LAC-Z treated muscle at the lower image, we see some CD31 expression, but no real E-selectin positivity. Then histologically, these are 2 images of just H&E staining, demonstrating overall the myofiber size is larger in the E-selectin treated mice, and also the morphology. The nuclei tend to remain at the periphery, which is what's observed in normal muscle, versus a centrally located nuclei in the LAC-Z treated mice, just demonstrating basically more ischemic damage. And again, those are quantified in the middle. And then for functional testing, we train the mice pre-op to run on the treadmill, and then test them, and then have them exercise post-operatively. And the E-selectin treated mice generally perform better on this testing. So as I mentioned in the beginning, the primary mechanism we believe this therapy works is by enhanced recruitment of endothelial progenitor cells to the areas of ischemia. And so here we performed staining for CD34 and CD31. CD34 is a marker of early endothelial progenitor cells, and we can see some co-localization of those signals in the E-selectin treated muscle, whereas there's much fewer CD34 positivity in the LAC-Z muscle. And then finally, just looking at any potential effects on inflammation, toxicity. E-selectin is involved in recruitment of leukocytes, and so we wanted to see whether it significantly affected inflammation in the ischemic muscle. And this is staining for MAP2, marker of macrophages, and we actually didn't observe any real significant infiltration of macrophages in either treatment groups. And then finally, E-selectin is also pro-thrombotic, and so we wanted to assess whether it was having a significant effect on coagulopathy. So we just measured serum D-dimer levels and did not find any significant difference between the E-selectin and laxity treated mice. And this final slide is just some very preliminary biosafety data looking at hepatic and renal function between E-selectin, laxity, and PBS treatments. There's no real difference between either of those. So in summary, in this preclinical mouse model of hind limb gangrene, we've shown that E-selectin AAV29 gene therapy can reduce the severity of tissue loss and skeletal muscle atrophy. It thereby improves recovery of hind limb perfusion and function. And we believe this is working primarily through enhanced recruitment of endothelial progenitor cells. And just with some preliminary data, it does not appear to have any significant pro-inflammatory or pro-thrombotic effects or systemic toxicity. Thank you, and I'm happy to take any questions if there's time.
So Dr. Ribieras,
Yes.
one of the issues with gene therapy that works in mice but doesn't always work in humans is that all the mouse models tend to be these acute ischemia models. Do you think that this therapy is going to be translatable to patients with long-established chronic PAD?
Yeah, absolutely. That's definitely a concern. And it's something we're testing in the lab, whether we can, of course, these models aren't directly translatable, but in the FEV model, the gangrene tends to develop over a period of 2 to 3 weeks, sort of subacutely. We're testing whether we can administer therapy after induction of ischemia and whether that still helps with reperfusion and the severity of gangrene. And then compared to other past clinical trials, those have generally used naked plasmids, which generally have poor uptake into the cells, poor efficiency of expression of that protein. So by using this vector, we hope we can really get high-level expression of E-selectin and longer-lasting effect.
So Dr. Glevitsky has a question about the fact that you ligate the femoral vein in addition to the artery in your model, because then it makes it look more like phlegmasia as opposed to a strict arterial ischemia like in humans.
Yeah, absolutely. This is the way we've been doing it in the lab. I agree it's not strictly a femoral, not strictly an ischemia model, and there's definitely some component of vascular congestion. We do it for the ease of the operation, and then histologically, we haven't really observed any significant evidence of thrombosis, and don't think it's really contributing. But I agree, when we could try to test it just with femoral artery ligation, absolutely.
Yeah, because multiple other groups have done just plain femoral artery ligation.
Absolutely.
It's not that technically challenging. So
Yeah,
I would encourage you to do that. Okay, so in the interest of time, we're going to move on to our last speaker, Dr. Takuya Tsurioka, who's going to be speaking on zinc deficiency impairs ischemia-induced angiogenesis. Dr. Tsurioka.
Thank you very much for the introduction and for reviewing our publishing our manuscript. PAD is increasing globally. In no less than half of PAD patients with chronic limb-threatening ischemia, CLTI, amputation of the affected limb is required, which reduces patients' quality of life. Zinc is an important essential trace metal that is involved in many physiologic functions. Some major health impacts of zinc deficiency include reduced growth rates and immune function suppression. With regard to cardiovascular disease, a high zinc intake status provides protection against cardiovascular disease. Recently, we investigated the relationship between zinc deficiency and clinical outcomes after bypass surgery for CLTI, and found that zinc deficiency is associated with lower rate of limb salvage. However, there is a lack of clarity on the impact of zinc deficiency in the regulation of angiogenesis. Here, we investigate the impact of zinc deficiency on ischemia-induced revascularization process, employing a mirroring hind limb ischemia model, and also examine the relationship between circulating zinc levels and SPP as an index of tissue-blood perfusion in patients with CLTI. Zinc deficiency was induced to a zinc-deficient diet to 3-week-old animals for 7 weeks. As shown in this slide, the zinc-deficient mice exhibit impaired blood flow recovery rate and decreases capillary density in the ischemic limb compared to the control wild-type mouse. We next investigate the production of ROS in the ischemic muscle. Ischemic injury increases the ROS production rates in the adductor muscle to a greater extent in the zinc-deficient mice than in the control mice. The serum level of D-LOM, an index of oxidative stress, was significantly greater in the zinc-deficient mice than in the control mice. Furthermore, the zinc-deficient mice showed higher expression levels of NADPH oxidase competence compared to the control mice. To examine whether excessive ROS production is involved in reducing the angiogenesis capacity caused by zinc deficiency, mice were treated with both a zinc deficient diet and the NADPH oxidase inhibitor apocynin in drinking water from 3 weeks of age. As shown in this slide, NADPH oxidase inhibitor ameliorated the zinc deficient induced impaired of revascularization. Finally, we examined the relationship between serum zinc levels and SPP as an index of tissue blood perfusion in patients with CLTI. This slide shows the clinical characteristics of the patients. Serum zinc levels were possibly associated with SPP in the CLTI patients. Multivariate regression analysis also revealed the serum zinc levels are significantly correlated with SPP in patients with CLTI. In summary, zinc deficiency contributes to impaired vascularization rates in response to tissue ischemia. Zinc deficiency led to an increase in the production of ROS. NADPH oxidase inhibitor ameliorated the zinc deficient induced impairment of this vascularization. Serum zinc levels were positively associated with SPP in patients with CLTI. In conclusion, zinc deficiency impairs the rate of revascularization in response to tissue ischemia, which is accompanied by oxidative damage. Nutritional approaches aimed to add the zinc take of zinc may be useful for prevention and or treatment of ischemic limb damage. Thank you for your attention.
So Dr. Soroka, other than using the NADPH inhibitor, did you have any other evidence that zinc deficiency was associated with elevated reactive oxygen species, like measuring plasma superoxide dismutase?
Thank you, great question. In our study, D-LOM measurement and digital staining are performed to evaluate the ROS of zinc deficiency model. We have not measured the SOD activity, but we believe that the evaluation of active oxygen expression by digital staining can be used as a substitute. However, since the digital staining has not been quantified, it cannot be shown as a graph. Also, although not shown here, we measure the ELISA of nitroglycerin. Nitroglycerin is a marker of nitric oxide delivered radical tissue damage. This study also shown the increase in plasma. Nitroglycerin is a zinc deficiency model. So the next question is kind of building after Dr. McEnaney's demonstration that, capillary angiogenesis is kind of dependent on a lot of factors, including muscle fiber regeneration versus fibrosis. Do you have any other measurement of arteriogenesis as opposed to angiogenesis, like smooth muscle actin staining or micro CT in your model? Thank you for a good question. We have traditionally evaluated limb perfusion by laser Doppler flow and evaluation by CD31 immunostain. And we believe that the actual accuracy is high because It is an established procedure. Therefore, we evaluate angiogenesis by performing CD31 immunostain and quantifying per muscle fiber. But we did not evaluate the density of muscle fiber itself or actin. As you asked, many factors are involved in angiogenesis. So in order to make a more accurate evaluation, it is desirable to evaluate actin by fluorescence staining and image evaluation by micro-CT.
Have you tried to supplement your patients, your PAD patients with zinc?
We tried now, and Dr. Kodama in Circulation Journal, we show the data.
Okay, I'm going to turn it back over to Dr. Dardik. I thank all the speakers for their participation and all the participants for joining us for this webinar.
Thank you very much, Dr. Tang. Appreciate the wonderful moderation of this webinar. I really want to thank all of our speakers, Dr. Qadura, Dr. Ribieras, Dr. Tsuruoka, for the wonderful presentations. Thank you, Dr. Tsuruoka, who's joining us from Japan with the late hour. We really appreciate it. This webinar has international reach, and we're delighted. And a special thank you to our keynote speaker, Dr. Ryan McEnaney, for just a wonderful talk. These webinars will be put on the homepage, www.jvs-VS.org, and I highly suggest that everybody please check out the wonderful papers there, especially by our three presenters today. Hope to see everybody in about 2 months in Seattle for the VRIC conference, and thank you very much for attending this webinar. Take care.